Okay, fantastic. So now you guys have had the preliminary on cataracts and cataract surgery. I'm just going to talk a little bit about when you pair it with glaucoma in a patient and how you can manage both problems in one session. I'm sure you're all kind of taken aback by the video because it is really the coolest thing ever. In all of medicine, it was the first cataract surgery I saw in medical school. It was like, that's it. I'm going into ophthalmology. Hell or high water. This is the coolest surgery possible. You could change a person's life in 5 minutes. You can go to any country in the world with a little bit of equipment and change a village in a week. I mean, it's really a privilege to be able to have this training and to be able to do it. And I just want to thank everyone who's undergone the procedure, because it's a lot to put yourself in somebody's hands and to trust that you're going to have sight when you come out. So it's a really cool thing for all parties involved. Okay, let's talk about glaucoma. What is glaucoma? You probably hear about it a lot. Well, it's when the optic nerve, which is the cable in the back of the eye that transmits the visual signal to the brain, it's when that optic nerve is damaged from high pressure in the eye. And usually that optic nerve is made up of 1.2 million individual nerve cells. You can lose about half of that before you start to lose your vision. But when you do, what happens is that usually the peripheral vision starts to fade. And I'm going to show you, this is what a healthy optic nerve looks like. This is the back of the eye. This orange stuff is the retina. This little speck here is the fovea, which is the center, the macula. If you heard of macular degeneration, that's the part that is affected. And here's the optic nerve. The center of the optic nerve has a little hole in it where all the blood vessels come out. And this should look like a donut, so that the hole in the center, which is what I'm highlighting here with this arrow, should take up no more than a third of the whole donut. But with glaucoma, what happens is the optic nerve gets damaged. The one on the left here is a healthy nerve, and over at the right, you see that hole in the donut is taking up 80% of the whole space. So the optic nerve is very, very damaged. Here's another image of it. A healthy optic nerve, one where half of the nerve is already kind of eaten away, and the one on the end, which is really late stage severe glaucoma. And that happens from pressure building up in the eye. And this is what a healthy person sees here, the whole image. And this is progressive glaucoma. The edges get blurred, progressively more blurred, and then you just have a little island of vision left, a little tunnel in late stages. And it happens so slowly that people usually don't know they have it. That's why it's called the silent thief of sight, because it develops so slow until they finally just have a little keyhole that they're seeing out of, and then they become aware that something is wrong. And for activities like driving, obviously, you can see how that's a big problem. Here's what the normal individual should be able to see, and in late stage glaucoma, the people are missing from the view. So pretty dangerous stuff. There's many different types of glaucoma. What we're going to focus on in this little few minutes we have together is open angle glaucoma, which is the garden variety most common type here in this part of the world. But there's something called angle closure, which is where the drainage system of the eye is completely closed. Open angle refers to the drainage system of the eye. The eye, just like it's always making fluid and draining fluid at the same time in order to be able to keep a certain pressure, just like a water balloon. And in glaucoma, the drainage system gets damaged, so pressure builds up, pushes on that optic nerve, and the optic nerve starts to get weaker, and then the damage occurs. And that's what we showed a little bit earlier. What are some of the risk factors for open angle glaucoma? The biggest one is family history, but also age. It increases as we get older. African Americans, Asians, and Hispanic patients tend to have the highest risk. Really severe myopia is another risk factor, long-term steroid use, having very thin corneas, which is something you're born with. It's not something that you develop or something that you're doing to cause it, or a history of severe eye trauma. Over 2 million people in the United States have diagnosed glaucoma. Have glaucoma. Half of these are undiagnosed. Why? Because, like we mentioned, it's not painful, the eye isn't red, there isn't discharge, there's no outward symptoms, so the patients typically don't know they have it. We normally start off with eye drops as treatment to lower the eye pressure, drops that make the eye either produce less fluid or help the drainage a little bit better. If that doesn't work, we can always go on to laser treatments that are done in the office, and then finally surgical intervention. But if you're already going into cataract surgery and you happen to have glaucoma, even if it's well controlled, it's a good opportunity to step in and take care of that at the same time. So not necessarily does surgical intervention fall at the far end of the treatment spectrum. Sometimes it can happen earlier on as well. Here is one of the main treatments. This is a tube shunt implant. And what we do is we place this implant, which is plastic, on the eye. We sew it onto the eyeball in between the muscles of the eye, and then we insert the tube portion into the eye, and it helps drain the fluid out into the back of the orbit. So there's no external drainage. Patient doesn't have tearing or anything like that, but it's like putting a little implant that sucks the fluid out for the patient. And this is what it looks like in an actual patient. So you have all the normal blood vessels, the cornea here, the iris, and here's the tube inside the eye. Here's another one. And this is the cataract here. You see how this is getting yellow, this lens behind the iris? Well, that's a delicious cataract ready to come out. And this is a trabeculectomy. This is another one of the standard glaucoma operations we do to take care of the drainage. And what we do is we remove the superficial layer of the eye. We make a little window out of the white part. This is the sclera. We lift that up, we punch a little hole in it with like a little paper punch type of thing, and that allows the fluid to filter out, and then we close it back up. And so all the drainage happens internally. It's like little percolating fluid. I'm going to show you a little video of one of my cases. Okay. So first, I'm just putting a little suture through the cornea in order to rotate the eye down so that I have nice exposure of the white part of the eye. And I'm making a little cut through the superficial layer of the eye. This is the conjunctiva. That's where all the blood vessels are and so on. When you have a red eye or a conjunctivitis, that's when this thing gets inflamed. And it's paper thin. It's thinner than paper. You can't even see it. Then a little bit of dissection underneath. I'm just putting my scissors underneath that thin layer. Do you see how it's see-through? You can see the scissors underneath. To make a pocket, that's where all the fluid is going to drain out for this patient so that they are not going to have any external drainage. And then you dissect all the way on both sides to make a nice pocket. This is a little sponge full of this medication that we put in to prevent scarring. Once we make that little window, we don't want the window to close. The eye's natural response, the body's natural response, is to heal itself, to make scar tissue. I don't want scar tissue, so we're going to put this material in there that prevents the eye from scarring, and then we remove those sponges and irrigate them out. So I've just removed those sponges here, and I'm just going to wash it out with some just some saline solution. And now I'm using a blade to make a half thickness. So I'm just going to cut half thickness. So I don't want to go all the way through. That would not be good. Half thickness, and then I'm going to raise that flap up by just teasing the tissue back and forth. It looks like I've got 3 hands, but that's because there's an assistant there with the sponge. So that's just lifting that white part in half of its thickness. You see the other half is still here. And then we're going to go in with a little blade to enter the eye, actually. Just barely tease up to the cornea. So I want to access the chamber of the eye, the front part, which is where all that fluid is building up. So I'm going to go in with this little blade, and I'm going to go all the way into the eye to create a passageway from the inside of the eye to this little pocket that we made here. Okay, now I'm going to go in with the little punch. This is the hole punch. And I'm going to take a little bite out of the eye. It's microscopic. It's like 200 microns, really small. So you won't ever be able to find that hole unless you use a magnifying lens. Okay, little punches. And now we're gonna, tiny little hole in there that connects this chamber where the fluid has built up to this little pocket we made here. I'm going to take a little piece of the iris out and cut it so that nothing clogs up that pretty hole. And then we're just going to close that down with some sutures, which are very, very thin. I mean, you need a microscope to see these sutures. They're thinner than a human hair. So, and they're tiny, tiny. We're going to close that business back up as if we were never there. But the fluid is going to continue to percolate through and replace the patient's own drainage system. And these are permanent sutures. These are made out of nylon material. So they'll be there for as long as the patient is, or as long as we want them to be, or we could take them out if we need to. And I usually do 3 of these. The third hand is coming in with the, okay, and then those are the stitches, 1, 2, 3. This thing is all closed back up. And then I close this tissue on the top, the conjunctiva, with 1 suture that I run along the eye in a continuous, and this is a dissolving suture. So once I'm done with this, it takes about 6 weeks for that suture to dissolve, and it's as if we were never there. And then we can go ahead and do the cataract portion of the surgery, which is done.
Can the cataract grow back?
No. No. What can happen is some, like I mentioned, scar tissue. The eye always wants to heal itself. That capsule that Dr. Farid talked about sometimes can develop a little scar tissue. We call that a secondary cataract, but that's really a misnomer. And how we deal with that is with a laser. We just pop a little hole in the back of it and it clears it right up. So that's the end of that thing, and it's as if, look, beautiful, and this patient's going to have good control of their eye pressure. Another procedure that we have is called a trabectome. It falls under the category of minimally invasive glaucoma surgery. It removes the clogged drain of the eye in a little strip, so 360 degrees of the drainage system of the eye. We usually take out about 90 to 120 degrees of it, and this is done at the same time as cataract surgery, but it doesn't have to be. You could have it separately, either before or after cataract surgery. So here is the drainage system of the eye. It's on the inside of the cornea. You need a special lens to be able to see it, and you'll see that in a minute. Here's where the cataract is, and this is the iris, which in this cartoon is blue. So this is the eye is always making fluid, and it filters in front of the lens, around the iris, and out through this drainage system. So this is the part of the eye that makes the fluid, this little business here. It's called the ciliary body. And when that drain isn't working, it pushes pressure on this optic nerve and thins it out like we talked about. It's very sad. Glaucoma is very sad, but the treatment is awesome. So we make a little incision there, and this is the special lens that helps us see what we're doing. And that's the device. We go in, and what it does is it basically, with cautery, it's a little micro cautery, removes a strip of that clogged tissue. And those are the little holes that the fluid drains out of afterwards. Those are natural to the eye. And the fluid just drains straight out. So it's really cool. And here is one of my cases from earlier this year. So in this patient, I've already removed the cataract, minutes earlier. Here's where the new lens is. I'm putting this special lens on the surface of the eye, inserted this handpiece through the same incision as the cataract procedure. So it doesn't involve an additional incision, or it doesn't even involve enlarging the incision. What it does involve is a suture through it. We always close that incision because it will leak after this. And what you see is this black business, this is all clogged with pigment. As you could see, the part that I've treated, there's a white stripe behind me. That white stripe is where I've removed a lot of that pigment. And so that white stripe is where the fluid is now going to go straight out. So it's just like cleaning the drain in your kitchen sink. Here is another quick video. So I'm doing a cataract here, just like you saw, breaking up the lens into a bunch of pieces, inserting that really cool lens, which is just going to magically open, and then placing the lens on the surface of the eye, this different type of lens, and the handpiece for the trabectome going in, and there we're removing. You see all that black business? Again, that black line is the clog, and we're just going to open up the clog, and you see there's that black line is gone now. It's just a white stripe. So that really helps patients with eye pressure control. There's something else you guys are going to hear a lot about. It's called the eye stent, and that's because it's fairly new on the market. It looks like this. It kind of looks like a bolt, except for it's hollow inside. And how this works is you stick this thing through that clog, and it allows fluid through the back end of it and then filters out through these holes into the eye's natural drainage system. And typically a couple of these are put in at the same time right after cataract surgery. So there's that black line, which is the clog drainage system. Let's see if I can get this thing to work. Okay, and you just go in after the cataract is out, and you insert the handpiece. You push right up against the clog, which is the trabecular meshwork, and you push the little plunger, and it deploys the little bolt into the drainage system. And it's just like a staple gun. You can go around and do a bunch of them. Yeah, that's the eye stent. So you can do, you know, just like a nail gun, boom, boom, boom. And those are permanent implants, so the patient will keep those in their eye, unlike what you saw earlier. There is yet another cool, nifty device that goes in through the clog drain. It's called the Hydrus. That's recently been FDA approved. It's really long and goes in through a large strip of the drainage system and has these little scalloped holes which allow the fluid to drain into. This video is super fast. If you blink, you'll miss it. And I'm pushing this thing in through, and you see it's threading through the clog drain. All done. So this whole business adds just minutes to the cataract operation. So, you know, we usually say about 10 to 15 minutes, but that's being really generous just to set up the microscope and all that. But it's a great opportunity to fix two problems in one session. And if a person has well-controlled eye pressure but doesn't like to use the drops and, you know, has side effects and so on, it's another opportunity to kind of minimize the reliance on medications, because often with these treatments you can reduce the amount of medication that the patient is on. But which one of these, a bunch of procedures I showed you, is right? It's very dependent on the patient, their eye, the whole system together. So it's worth a good conversation with your doctor about what's best and what your goals are in specific. I just wanted to mention a couple things about what's going on here at the Gavin Herbert Eye Institute. We're very privileged to be a part of this family because at the Gavin Herbert Eye Institute, we develop programs and technologies and clinical solutions to help people with their eye problems. This is the cutting edge of technology. We're a national and an international clinical trial center. And of all the things I talked about, which is everything that's on the market, this was a comprehensive discussion about glaucoma surgery, and everything that Dr. Farid talked about, the eye stent was invented here, the trabectome was invented here, the tube shunt was invented by one of our doctors, and the femtosecond laser was invented here at UCI. All of those things. So we're very privileged and proud to be a part of this, and stem cell research is probably the next wave of innovative things that will help people, and we're one of the main trial centers and major grant recipients for stem cell research. We train residents here, we have fellows, and so we're always learning from them and hopefully kind of elevating the next generation of thinkers and leaders. Yes, there was a question here? Again, it's patient dependent. It depends on their situation and their stage. Yeah. Yes, there's several stem cell clinical trials going on, in particular for macular degeneration. Just like any other patient. It's a referral. We have to evaluate them to see if they meet all the inclusion criteria, if they don't have any of the exclusion criteria, and so on. Our stem cell studies are macular degeneration studies right now and retinitis pigmentosa. So if you have...
How do we get our patients today?
We have a retinal division with several doctors that do just that. And so you would refer someone to see the retina doctors here. We have a business cards at the front we can give you. I'd be happy to do that. So let me just back up because I do have some slides here on that. Basically what tamsulosin or Flomax, which is what we're talking about, can do is that it can cause floppy iris, intraoperative floppy iris syndrome, so where the iris starts to billow around and it can get sucked into the tip of that little vacuum that you saw. It can get in the way of what we're trying to do. And it can also constrict and start to become really small so we can't access the lens. So what we can do is what we use iris retractors. We can pull back the iris and keep it stationary so it doesn't get in the way. And the medications we use in the eye also help, like intraocular lidocaine helps to keep the eye quiet, and some. So it's really a mutual decision. It's not the doctor's decision or the patient's decision alone. It has to be a partnership based on your goals and what's realistic to achieve. If you have a pressure in the 20s, normal is between 10 and 21, and your pressure is 25, for example, and if your doctor thinks that a pressure of 16 would be acceptable for you, then a certain category of those treatments that we talked about are appropriate. But if your pressure is 16, and what you really need is a pressure of 10, is determined by your doctor and your optic nerve status, then only a couple of those things I talked about would be appropriate. It's very patient dependent, and so it involves a conversation with your doctor. No, not necessarily. There are certain times when that would be appropriate. For example, if you have a really strong prescription, you're very nearsighted or very farsighted, and you only have cataracts in one eye and the cataract is removed and a lens is put in so that you could see perfect without glasses. The other eye, it's hard to wear glasses that has a big power prescription in one eye and a blank in the other. It makes you kind of wonky and dizzy. And so that would be an indication to do the other eye, but not under normal circumstances. No, you can leave it. The same surgeon does both. Dr. Farid, did you want to take this one? Sure.
Yeah, well,
I don't want to hog the mic.
A lot of patients with macular degeneration will ask this. If the cataract is very dense, remember macular degeneration affects that central part of the vision. Unlike glaucoma, which Dr. Mosaed mentioned affects the peripheral vision, macular degeneration is very central. But the cataract can still really impact, if it's pretty dense, the peripheral vision, which a lot of macular degeneration patients rely on for walking around. You're using that peripheral vision. So cataract surgery can often still benefit a patient even who has dense macular degeneration because it'll improve the peripheral vision. It usually does not cause a worsening of the macular degeneration in most cases, but we do monitor very carefully the macula after cataract surgery.
So what do you do if it does cause worsening?
Well, if you're in an institution like this where we all work very closely, we have glaucoma surgeons, retina specialists, cataract surgeons, we're all working very closely together, then we make sure you get in for the proper treatment. There's a lot of advances in macular degeneration as well that's sort of beyond the scope of today's talk, but that can be very beneficial. I hate it when somebody thinks that because they're paying more, it's a better lens. They're all fantastic lenses. It really depends on the patient and what their visual requirements are. So there isn't a better lens. Sometimes that's the worst lens. If you come in and you've got glaucoma or macular degeneration and you pay for this multifocal lens, that's the worst lens for you. So it doesn't have anything to do with that, really. Because for a multifocal lens, you need a really perfect eye because you're already compromising some, you're adding some optical variability to that eye. And now if you have glaucoma or you have other issues that are causing your contrast sensitivity to already be low, we don't want to add another confounding.
Unless you have astigmatism that's significant. If you have significant astigmatism and you want to see distance without glasses, then you need to talk to your doctor about the toric lens, which is the astigmatism neutralizing lens. But if you don't have significant corneal astigmatism, then the standard lens, which is covered by insurance, is a fantastic lens. So I would stay away from using the word better. You cannot prevent glaucoma through diet or supplements. If we could choose our heredity, that would be something to do. There are certain supplements that are recommended for people who already are at very high risk and have a precursor, a specific.
No problems, just prevent.
No, healthy diet is the recommended for everything. This is a very complex question, but if your distance eye is the eye that has the worst glaucoma, obviously you're going to be impaired to some degree. If your near eye, it tends to not be as bad because you can always put reading glasses on the distance eye and make that a near eye when you need it. But I wouldn't worry about it. You're here now. The lenses are already in the eye, and just enjoy your vision, move forward. Normal eye pressure is between 10 and 20, unless you have something called low pressure glaucoma, which is where all that damage still happens in the normal range, in which case we recommend a lower pressure, something on the lower end of normal. So it depends on everything, the status of your optic nerve, what kind of eye pressures you had while developing the optic nerve damage, the corneal thickness, on and on and on. So it's not a number I can spit out for you here, but it would require a detailed evaluation of your eye status.
There's many things in the eye that can cause low contrast, the glaucoma being one of them. It can affect your contrast, optic nerve disease, macular disease,
Cataract.
cataract.
Cataract. And macular degeneration also?
No, it's different. That causes
So
different
mostly
symptoms.
glaucoma and cataract.
Yeah. Right, so it's not always the same as what's in your glasses. So some people say, I have an astigmatism because my glasses require an astigmatism. This refers to just the shape of your cornea, what we're talking about. What goes into your glasses needs is a combination of your lens and your cornea together, which sometimes neutralize each other, sometimes are exacerbated by one another. We are going to take that lens out. So we're going to take that business out of the equation. We're only going to measure the corneal curvature and give you a lens that, or a recommendation for a lens that fits the curvature of that cornea.
Keratoconus, can cause irregular astigmatism or regular astigmatism sometimes. So patients with keratoconus, a small percentage of them can do well with a toric lens. Most cannot because of the irregularity of their astigmatism. But we have other options for that, like scleral lenses and things like that.
Typically not. Typically the Flonase that everyone's buying at Costco, it tends to be okay unless you have glaucoma. If you have glaucoma, you should avoid the nasal inhaled steroids until you see your doctor and see what status you're at. But typically those inhaled steroids aren't a big deal.
Because they're very localized. So it's rare for them to cause a cataract. Now, if you've been your whole life, you've taken steroids on and off orally or certainly IV steroids, then you can get cataracts a little bit earlier in life. We use a gel drop on the eye that numbs the eye. Yeah, it's also patient to patient dependent. It's something like a mild Versed,
It's a mild sedative.
mild sedative.
You don't have to use it.
You don't have to, no. It's usually that. Sometimes we add a little propofol if the patient's really nervous. It depends on the patient's anxiety level.
Heat is applied to the eyelid glands with a massage sequence to help unclog the oil glands of the eyelids. That improves the oils in the tear film.
It's like your eyelids going to the spa.
Yeah. Really good question. So dry eye is a big confounding problem in cataract surgery because we want to get good measurements so that we can make sure we make the right lens selections. And dry eyes tends to get a little worse right after cataract surgery. So the more we improve your tear quality and your tear stability, the better you do afterwards, the better we do with our measurements. Now, in some patients who have severe clogging of the oil glands and who have really an oil gland issue, sometimes a Lipiflow treatment before a month or 6 weeks before the cataract surgery can be helpful.
We're talking about the eyelids, tear glands in the
Lipiflow
eyelids.
is a procedure we do for dry eyes that involves, it's an in-office procedure for dry eyes. There are hot compress. The towels don't work so well, but if you get these masks that you can heat in the microwave, and you put those on 5 to 10 minutes every night, they also help the oil glands start to flow better and helps the dry eyes.
There are always risks to cataract surgery. It is one of the lowest risk surgeries performed in the United States, but everything has risk. For example, that capsule that was described can have some compromise in it and bits of the lens can be retained in the eye. Not all of it can come out. A retinal detachment can occur. The cornea can be damaged. All these things. It's less than 1% of patients who develop a problem, but everything has risk. Eating an apple has risk. Waking up in the morning has risk. Driving out of your driveway has risk. Of course. So anything can happen, and it's unclear what was going on in this person's eye beforehand. Lots of times the cataract can become so dense that it's hard to see what the status of the retina and the optic nerve are in the back. And we take the cataract out and we look in and we see, oh, this person has really severe diabetic retinal problems or whatever else. And so the vision improvement isn't quite as robust as one might have hoped. But there's a lot that can be going on in an eye. It's a very complex with lots of different parts. Yeah, there's a lot of preliminary work looking at regenerating the optic nerve because right now any vision loss from glaucoma is permanent. Unlike cataracts, where any vision you lose from cataracts is reversible with the surgery, any vision loss from glaucoma is irreversible at this time.
Very good question. There's multiple factors. So it could be the drops that we have you on after surgery. They have preservatives. Those preservatives can irritate the ocular surface. During the cataract surgery itself, you have the incisions, you have the eye open for a few minutes, even though we're moisturizing it the whole time. All of these things lead to a little bit worsening dry eyes after cataract surgery.
Is that temporary or permanent?
It's temporary if you take good care of it, but it can become permanent if it's ignored.
But what's temporary? Temporary can sometimes be several weeks to a couple months. And so, you have to be aware of that.
Yep. Perfect. Thank you so much. Thank you for listening.